My name is James Weisberg. I am a pain psychologist here at UAB, associate professor in the Department of Anesthesiology at UAB. I evaluate and treat patients mostly with chronic non-malignant types of pain using a variety of cognitive and behavioral strategies to try to maximize their function and minimize the effect that the pain is having on their day-to-day lives. Within the pain clinic itself, we have two specialties, physicians and psychologists. We are hoping to expand and expect to expand and add some pastoral counseling, as well as possibly massage and acupuncture. We also have very close proximity to the workplace and physical therapists and occupational therapists. One of the unique things about the UAB pain clinic is that we are all in the same central location. So for example, if I'm seeing a patient for cognitive behavioral pain management and I have a concern about a medication, I can walk to the other side of the clinic and ask one of my physician colleagues whatever my concern is. Likewise, they'll walk over and express to me when they have concerns that need to be immediately addressed. So pain psychologists, most of us are clinical psychologists by training, PhD in clinical psychology, and then have done a fellowship in pain management. We know that from, again, research that's been done over the last 50 years, there are a number of specific cognitive behavioral strategies. In other words, mind-body medicine, basically. It's no longer considered complementary or alternative. It's really integrative care, teaching patients how to relax their bodies physiologically as well as relax and calm their mind. Again, we have some evidence by fMRI that relaxation kind of decreases some of the hyperactivity of the nervous system. So teaching different relaxation strategies that patients can use real time when they're hurting. Teaching them how to pace their activities. Very often patients with chronic pain feel that when things are going well for them, when their pain levels are relatively low, they got to get everything done. So they work really hard and then they kind of crash and burn with pain later on. And sometimes they don't understand those connections. So helping them kind of learn what sorts of activities may flare them up and how to pace those activities and how to make a conscious decision. I want to do activity X, but I know that I may have pain afterwards. Again, we know from clinic and from research that making this decision a priori or before going ahead and doing it actually decreases the after effects of pain, because you've consciously made a decision. I want to do this despite the fact that I may hurt. What are some of the things that I can do to minimize the amount of hurt afterwards? Learning how to pace oneself, using your medications judiciously, using relaxation techniques, things of that nature. So as pain psychologists, we have in our arsenal a number of different strategies and techniques that we try to impart upon our patients. Relaxation techniques are one, activity pacing are another, pain acceptance and acceptance of chronic illnesses that are often comorbid with pain, sleep hygiene. As we know, a lot of pain patients have difficulties with sleep. We used to think that it was unidirectional. The typical patient will come in and say, I can't sleep because of my pain. And if we treat the pain more effectively, they'll sleep better. We now know that poor sleep quality affects subsequent pain levels. And a lot of patients have comorbid sleep disorders, whether it be obstructive sleep apnea, restless leg, periodic limb movement disorders, REM sleep disorders. We know that there's a high correlation with chronic pain patients. So we see a lot of patients that have been in the sleep center and vice versa. One of the other things that we do as a pain psychologist is use biofeedback. And biofeedback is merely real-time visual and or audio feedback about some of the autonomic nervous system functions, such as heart rate, peripheral skin temperature, surface EMG monitoring. And by getting this real-time information via sensors that a patient is attached to, they learn the process much more rapidly. It's, again, a conditioning model, an operant-respondent conditioning model. And by seeing or hearing that reinforcement, when I think about X, my heart rate goes up and my muscles tense up. But when I think about Y, my heart rate comes down and my muscles relax. And making that connection much more rapidly usually occurs when we use biofeedback. Another one of the roles of a pain psychologist is to assess patients pre-procedurally. We have a lot of research that demonstrates that undergoing a psychological evaluation or psychiatric evaluation prior to inserting a spinal cord stimulator or an intrathecal pump greatly enhances the efficacy of that procedure. In fact, many insurance companies require that the patient be evaluated by a psychologist before undergoing those procedures, or spine surgery or other invasive procedures, to assess whether or not they understand the procedure, whether they're cognitively intact to follow through with the aftercare, whether their goals and expectations are consistent with what the procedure will provide, and whether or not there are any red flags such as untreated depression or anxiety. We know that depression and anxiety is comorbid in about 50% of individuals with chronic pain. We also know that, unfortunately, depression and anxiety is overlooked all too often, and that if we can address that depression or anxiety, it helps manage the pain as well and increases their outcomes in interventional and non-interventional pain management. So does bringing in a psychologist mean that the physician doesn't believe the patient has pain? That's probably one of the biggest challenges that we have, is the stigma of referring a patient to a mental health provider of any sort. It's unfortunate that it's a stigma in 2015, but it still is. One of the key elements is to explain to the patient the reason for the referral. It's not because the provider, the referring physician, believes that the pain isn't real. It's not because the referring physician believes that they are making something up. It's because either they're concerned about comorbid mood disorders, and or they believe that the patient would benefit from the strategies that we teach them to better self-manage their pain, to become less reliant on medications and on others, and more reliant on themselves. So no, our general belief is that, is pain in the mind? Yeah, it's in the brain. It's a chronic condition with, again, changes that occur in the central nervous system. And pain psychologists try to capitalize and make those changes more positive. So the best way to explain it to a patient when referring is to say, I'm referring you to a pain psychologist. I know your pain is real. We don't dispute that. But they can help you learn strategies to better manage your pain and to hopefully improve your daily function. Some of the specific modalities, really it's kind of a four-pronged approach. And this all comes out of extensive research and meta-analyses that have been done on studies that have shown that teaching patients how to self-monitor, how to look at patterns for their pain, how their pain patterns may intersect with their emotions or activity levels, better understanding, better education, so we educate them about chronic pain. Again, that chronic pain is not necessarily a warning sign of damage being done, and in fact it usually isn't a warning sign of damage being done. Educating them about depression and anxiety so that they don't feel they're the only ones. So education is kind of one of the key components. Different relaxation techniques, physical and mind-based relaxation techniques, learning to invoke the parasympathetic nervous system rather than the sympathetic nervous system, which becomes keyed up over time. So teaching them what we call progressive muscle relaxation, autogenic relaxation techniques, some brief relaxation techniques that they can do in real life, such as when they're being interviewed on camera, using biofeedback to augment and to facilitate that learning process. So relaxation techniques are kind of prong 2. Prong 3 are the cognitive strategies, learning how to distract oneself from pain, learning how to think differently about the pain. A lot of patients tend to catastrophize or think the worst. We know that catastrophizing is a predictor of poor outcome, an outcome being defined as decreased physical function and increased pain perception. So if we can teach patients how to not catastrophize, but to use coping self-statements. Yeah, my pain may be bad today, but I'll get through it, instead of this pain is killing me. Again, there seem to be actual changes in the nervous system that occur when patients can alter their thought processes. These come directly out of the research on cognitive behavioral therapy for depression and anxiety, and have been adapted for pain over the last 50 years because of the research efficacy. So different cognitive strategies, and then lastly, behavioral strategies, teaching patients how to pace their activities based on time. We want to get away from pain being the main determinant in when patients take medications or when they do a certain activity or not, but make time contingent activities, time contingent medications as much as possible. So activity pacing, learning how to be more assertive and get their needs met in appropriate ways. Very often these individuals may be overly passive or sometimes overly aggressive. Well, one of the things that pain psychologists try to do is help work with patients to get their needs met appropriately, not calling their primary care provider every time that they hurt, but learning to go through certain steps before they make that phone call. And often that phone call then becomes unnecessary because those steps have been beneficial.